Hi, good evening. Can everyone hear me? Thumbs up. Nick Blondin can hear me. Ranjit can hear me. All right, so two people can hear me. Thank you to everyone for coming. I'm Jen Moliterno. I'm the Chief of Neurosurgical Oncology at Yale, and we're excited to welcome everyone here. This is billed as a CME event, but there's also patients and families, of course, that are coming in addition to providers. So the more the merrier, and we're really excited for tonight, and we look forward to doing this more in the future as well. I wanted to start by acknowledging Susie Beris, whose name this CME event holds. She's a dear patient of mine as well as Nick's, who was a pediatrician and was diagnosed with a glioblastoma 2 years ago and has done incredibly and remarkably well. And it's her generosity that allows us to do these types of events. So thank you to Susie. So with that, we will start. What we're going to talk about tonight is really the state-of-the-art treatment of primary brain tumors. And we're going to start with myself talking about the neurosurgical approach to brain tumors. And then Dr. Blondin is going to follow me with a neuro-oncology perspective. Dr. Ranjit Bindra to follow him, radiation oncology, as well as other types of research I imagine he will also touch upon. And then Dr. Antonio Omuro, who will finish it off, talking about clinical trials and the offerings that we have. We'll take questions at the end. We'll also take questions after each talk, seeing how the timing is working out, and we'll go from there. This should be fairly informal, and we hope that you enjoy it. So let me begin by sharing my screen. Does everyone see my screen? Is that a thumbs up? Okay, all right. I just see Nick and Ranjit, so I'll go based on them. So if they start to look bored, then I'll just stop talking. All right, so again, welcome. I'm going to talk about the neurosurgical management of primary brain tumors. As I mentioned, this is our group, our leadership group for the Brain Tumor Center, and this was at our most recent retreat, which was a great event. One second. Okay. So we are the premier academic neuro-oncology and neurosurgical oncology program in Connecticut. And we are fortunate to have the highest volume of cases, of brain tumor cases, and see the most number of brain tumor patients. As such, especially as neurosurgeons, we're frequently referred the more complex neurosurgical oncology cases by other neurosurgeons across the region and beyond. What this leads to is the more marquee cases, the types of tumors that are in more eloquent brain, for instance, or more functional anatomy that really entrusts our care. And I'm going to focus my talk tonight on gliomas as well as meningiomas, just thinking that might be most interest to the community. Every tumor that we operate on undergoes whole exome sequencing. And then we have a multidisciplinary tumor board where all of us sit. I lead it, as well as a precision brain tumor board where we really personalize the care for each and every patient. This was some data that I had presented about our brain tumor center and specifically about the neurosurgical oncology aspect of it. This was pulled from 2017, so actually has increased quite a bit since then, but I wanted to be honest with the numbers. So we have about half the share of neurosurgical oncology discharges throughout the state. I am fortunate to be the busiest brain tumor surgeon, but the other two busiest brain tumor surgeons are in our center as well. And we run domestic and international programs. This is a typical practice for us in neurosurgical oncology. And so you can see here glioblastoma involving the motor strip, large CP angle tumors such as epidermoids. Here are some atypical meningiomas, as well as intraventricular tumors. And again, these are just some more cases that we frequently see. Again, meningiomas, CP angle tumors, large acoustic neuromas, intraventricular tumors, epidermoid tumors that have been reoperated typically in the past as well. So our mission, which is likely similar to all the other providers that are on here, is to improve our patients' quantity and quality of life. And the way that we try to do that is to provide the most excellent patient care possible. We have advanced techniques and expertise, as well as the resources and the infrastructure to do that. Again, as I mentioned, we have a multidisciplinary treatment program, and we're always happy and willing to provide that with the community as well. And then we offer our patients support, realizing what a difficult diagnosis of brain tumor can be. So the goals of primary brain tumor surgery, of course, one is to establish the diagnosis to guide further treatment, recognizing that surgery alone is not the answer in most tumors. And really, we aim to resect as much tumor as safely as possible. There's some exceptions to this, of course, they're very few. This not only helps the patients from a symptomatic standpoint, but really has shown across the board to have overall and progression-free survival benefits in various types of tumors, all tumors for the most part, especially gliomas and meningiomas, which we'll talk about tonight. And of course, the tissue that we obtain from the surgeries can help guide more personalized treatment as well. So what I like to say is we have ways to make what others deem as inoperable tumors operable. And so there's some reasons and tricks that allow us to do that. So for one, we have subspecialized expertise. And so Veronica Chang and Joe Pietmeyer on there in that picture with me. All we do is brain tumor surgery, and our brain tumor surgeons, all they do is brain tumor surgery. And in fact, we're even further subspecialized into primary brain tumors and metastatic brain tumors, et cetera. And so there really is something to be said for neurosurgeons who do the same type of subspecialty surgery day in and day out. We similarly have advanced imaging capabilities. So Rob Fulbright, for instance, are one of our amazing neuroradiologists, as well as others, allow us to understand the function of the brain. And so functional MRIs and other more sophisticated imaging techniques that guide us in surgery. We use GPS system, which is standard on all of our cases. And then also, in addition to that, I typically use the ultrasound in every case. I'm not sure if my mouse is coming up, probably. Ranjit says yes, but that big white thing in the middle is the brain tumor, and then the little black thing in the middle is the carotid artery. So understanding the relationship between the two is, of course, important, but also allows me to know how much tumor I have removed during the surgery, and so I can always go back and remove more if it's safe. The gold standard to really maximizing the extent of resection is the intraoperative MRI. And so we're the only center in the state of Connecticut that has a 3 Tesla MRI, or any MRI actually, in our operating room, which you can see we're standing in front of, and I'll show you an example of that later. And it really does make a difference in terms of the outcomes and how much we're able to remove. Going back to our subspecialized expertise, we're able to perform functional mapping and more sophisticated microsurgery, which relies on neurophysiology. It's standard on nearly all of our cases, and really the gold standard to that also is awake craniotomy that allows us to operate in functional parts of the brain that others would deem inoperable and just rely on a biopsy rather than try to maximize resection. This was a slide that was given to me by the chair of MGH, which I really like. It shows that the more specialized the surgeon is in cranial surgery and brain surgery, the better the patients do. And I think that's even more true for brain tumor surgery, meaning that to have specialists who only do brain tumor surgery, the outcomes are that much better. And that's, again, what we're most interested in. And then, of course, recognizing that it doesn't end with surgery. And relying on our colleagues in neuro-oncology, radiation oncology, and then novel therapies as well to really push the field forward. So I wanted to use a few case illustrations just to showcase what we're able to do, and also drive home the point of how important the maximization of extent of resection is. maximizing. So this is a patient actually that Dr. Blondin referred to me. And we see things like this all too common in our practice, unfortunately. So this was a patient who presented with aphasia. And you can see at the outside hospital, this was his scan in December 2018. He underwent craniotomy for tumor. This is his post-op CT. And then this is his post-op MRI done in January. And you don't have to be a brain surgeon to see that the tumor that's here, which is a glioblastoma, which is in the left side of his brain, which is near the language, is very similar in appearance to before surgery. And again, we see this unfortunately because other people don't have the capabilities that we might. So he was kindly referred to me. We ended up getting that functional MRI imaging that I had mentioned, which allows us to understand the important function of the brain. And I ended up keeping him awake during surgery and was able to remove all of it. And he was able to go on and be treated with adjuvant therapy, and his aphasia improved even more importantly. So again, being able to do these types of things, awake craniotomy and other more sophisticated surgery, can really help patients. This is just a slide about our awake craniotomy protocol. And so some patients get nervous about the idea of awake craniotomy. And actually, it's one of the safest procedures that we perform and incredibly well tolerated. And I have a video to share about that. We rely on our great collaboration with neuroanesthesia. And so that's Dr. Shilpa Rao. She's a neuroanesthesiologist. Who really makes sure that the patient is comfortable and can tolerate being awake. And we reserve this when we're operating in areas such as these with tumors that are near the language area or even near the motor area. And again, this allows us to maintain patient's function. So the following is about a 4-minute video or so. I hope you don't mind, but I think it really showcases nicely in terms of these procedures.
To a Fox 61 exclusive now, it's
a
nightmare scenario when undergoing surgery, waking up in the middle of the procedure and knowing what's going on. But in some cases, that can be a lifesaver.
Lifesaver and necessary. We're going to explain that in a moment, but first we do want to introduce you to a man named Andy. Andy is a husband and father of 2 kids and a nurse. Another interesting fact about him, he's also a professionally trained singer. He's even performed with his church choir at Carnegie Hall. But Andy felt his entire life come to a halt when he was diagnosed with brain cancer. He needed surgery to remove as much of a tumor as possible, that tumor in the part of his brain that controls speech and, yes, singing. That's where a special surgery comes in. Surgeons at Yale New Haven Smilow Cancer Hospital have perfected a procedure called an awake craniotomy. They invited us into the operating room, and we did not hesitate to see this incredible procedure firsthand. In an operating room at Yale New Haven Hospital, doctors are working to remove a tumor from the brain of a 31-year-old man named Andy.
He is a singer.
He is?
Yeah.
A husband and father of 2. For most surgeries, waking up in the middle of the operation would be a disaster.
So he is asleep during the initial approach.
Doing his best to make sure Andy
and then we wake him up.
Stay still. Very good. I need stay still.
Surgeons have drilled through his skull and have already begun to remove part of a tumor located on the left side of his temporal lobe, the area which controls language.
You're doing great.
Medical staff puts a microphone on him. It's not for our cameras. It's so the entire room, including the operating surgeon, can hear what Andy has to say.
5, 4, 3, 2, 1.
The procedure is called an awake craniotomy.
I do have a headache. I was telling you earlier, I don't know if it's from the brain surgery or the fact that I haven't had a cup of coffee this morning.
Neurophysiologist Brooke Callahan sits next to him and begins her work.
I am going to say a sentence, and I want you to repeat it after me. The seashore smells like salt.
The seashore smells like salt.
Good.
Their interaction can be heard on a speaker throughout the room. Neurosurgeon Dr. Jennifer Moliterno has mastered multitasking, operating, and listening.
Are we okay?
Yeah, he's doing great.
Dr. Moliterno and her team work diligently to remove as much of the tumor as possible. What she can't see are critical microscopic language fibers which are splayed over the tumor.
The best way to try to remove as much tumor and preserve his language is to do it with him awake.
Get too close to those critical fibers, you'll know it.
What do you do in a chair?
So here he loses his speech.
I don't know.
You doing okay?
Yeah, a little bit of confusion.
So that's a great way to me to tell me to stop. And so even though there might be a little bit of tumor there, the risk and benefit of removing that tumor and having him not speak for the rest of his life tells you exactly what the right decision is. If he was asleep, I would have had no idea.
As Dr. Moliterno continues operating in a safer spot, Andy surprises us when this happens.
He does.
In the middle of surgery, Andy, a classically trained singer, shares his talent. 2.5 hours into the procedure, Dr. Moliterno decides it's time to wrap up.
The surgeons are done with the first part of the surgery. So what's happening now is they're bringing in an MRI machine and they're going to look at the work that they did and see how much of the tumor they were able to remove.
We go into another room and are able to sit with Dr. Moliterno as she analyzes her work. The before
Here is the tumor.
and after.
You can start to see here. It's not there.
You don't have to go back in. You feel satisfied.
I feel really satisfied. Him being awake allowed us to get that outcome and preserve his function.
Now, Andy was back home with his family 2 days after surgery. 5 days after the surgery, he was able to sing at his son's baptism. He's also sang again with his church choir and the Yale Camerata, which is a professional choir, just a couple of weeks ago. Andy is undergoing chemotherapy and radiation, but he does say he's feeling good. And of course, warm wishes to him. He is just a great guy.
And so that is exactly the reason we do what we do. Oops. This is another example of how we don't necessarily need to keep patients awake, but they do benefit from being more aggressive with surgery. So this was a patient back in 2013 who underwent a biopsy because it was felt that the tumor that's here, deep within the brain, was too dangerous to remove. So he underwent a biopsy, came back as a glioblastoma. He was referred then to me by the oncologist in the area, and I felt that I could remove it safely. And so I ended up doing an intraparietal sulcal approach and remove the tumor. Here's a good example of how, even for a brain tumor surgeon such as myself, this is our intraoperative MRI. This is the intraoperative scan, and you can see I left a little bit of tumor there. And so that's the benefit of having that intraoperative MRI, because sometimes a little bit of tumor gets tucked underneath the brain and you can miss it, even I can miss it. So I went back and ended up getting a nice gross total resection on him in that same setting with that MRI. Of course, it came back as glioblastoma with a poor profile, and he remained neurologically intact. He went on to undergo standard treatment with Joachim Behring as his neuro-oncologist. He enrolled on a clinical trial of Dr. Bindra's, and then switched to another clinical trial over the years, and then ultimately was continued on bevacizumab and progressed about 3.5 years following his initial surgery. And I'm sure Ranjit will talk more about his trials. This was his recurrence here. So he was referred back to me. This is 2017. The initial surgery was 2013. Referred back to me. I ended up doing a much wider resection of his tumor this time. And this is exactly what our path reports look like, in the sense that not only do we know that it's a GBM and have some of the molecular makeup, but with the whole exome sequencing, we're able to really understand the genomic makeup. And so here what we found was that his tumor had become a hypermutated tumor phenotype. These tumors we know are incredibly responsive to immune-mediated checkpoint inhibitors. He was started on nivolumab as a result. He continued for the next couple of years or so on Nevo, and then switched to Avastin, and then actually both back and forth. And in 2018, he had some recurrence, his Avastin was stopped, and I resected him again. And so 7 years, nearly 7 years this December, he will be out from his initial glioblastoma surgery. And so, as I always say, it's not that all of our patients will survive 7 years with glioblastoma. I wish that was certainly the case, but it is definitely the case in his. And I think that it was really being aggressive with surgery, having novel therapeutics, which we have, and then also just continuing at it and understanding the genomics of the tumor that allowed us to really tackle his tumor so well. I do know for a fact if he had stopped at the biopsy, he certainly would not be alive now. And so that's where aggressive surgery really matters. I just want to switch gears quickly to meningiomas, because I think this is something important to talk about, especially for community providers. What we're understanding more and more is that these tumors are not as benign as once thought. And understanding the tumor biology is really important, and that's something that we try to do here at Yale. This is a patient who was referred to me, who initially had surgery in 2015 or 14, I can't see on my slide, and underwent surgery at another hospital in Connecticut. This is his recurrence in 2017. At that point, he had went to New York City, underwent radiosurgery, and unfortunately was complicated by a lot of medical problems related. He had intractable seizures and weakness. He continued to have growth, as you can see, between 2017 and 2019. 2019, he was referred to me when he was in a wheelchair with intractable seizures. So the question is whether or not we could have predicted this better the first time around. And you can see here, he underwent a gross total resection. But again, could this have been handled differently initially? This is a similar case of a patient who underwent, I don't have his initial scan, but had a small meningioma that was in this area, was also told, similar to the initial patient, that it was a benign meningioma, and he was lost to follow-up. He returned in 2016 with visual problems. His neurosurgeon then sent him to me, and we performed a gross total resection of his tumor with the helps of Mike Alperovich from Plastics and Reconstructive Surgery, as well as Ben Judson, and reconstructed. This is just some muscle to form a flap and seal it off. But could this have been managed differently the first time, and why are these benign meningiomas behaving this way? And so the last 10 years or so, we as well as others have really understood or begun to understand the genomic landscape of meningiomas. And we know that there's specific genomic subgroups that underlie grade 1 meningiomas, and these are the driver mutations that cause these tumors to occur rather. We also have unveiled pathways to aggressive meningioma in the lab for part of it, but also clinically, as we have here. And so we use this information in real time. In a paper that just came out this past week in Neuro-Oncology, we looked at our experience with meningiomas and basically found that molecular subgroups itself, the driving mutation that's causing these tumors to form, that these subgroups have divergent clinical courses at 2 years of follow-up. And so there's aggressive types of grade 1 tumors versus more benign types of grade 1 tumors. So all grade 1 meningiomas are not created equally. And that's basically what we've shown here. This was really the first of that study to do that. What we also have found and published previously is that these subgroups localize, as you can see, along the skull base. And again, I can go into this in further detail at another time, but just the take-home point is that not all grade 1 meningiomas behave benign. So it's very important to be aggressive with them. And so this first case example that I gave turned out was not benign. This was an atypical meningioma. This was the pathology report that we received, as well as the whole exome sequencing information. And what this told us, based on what we know, was that this was initially a grade 2 tumor when he was initially diagnosed, but unfortunately was not diagnosed properly. And so again, goes back to the benefits of having a center that does this routinely, a center that has experts that are really dedicated to understanding this at a much deeper level. And that's what leads us to our precision brain tumor treatment program, which I discussed and my colleagues will also discuss. We have all of our patients navigate through our program knowing that multidisciplinary programs can be tricky and overwhelming, and so we try to organize that as best as possible. We offer a brain tumor support group, which meets monthly. We have an acoustic neuroma support group that meets quarterly. And then, of course, we have funding for our patients. And so Connecticut Brain Tumor Alliance, we've partnered with for years, which has been incredibly helpful for patient support, as well as for research. And the Lovemark Foundation more recently has donated $350,000 to us so far, with every cent going to our patients to help them get through treatment. So in summary, from a surgical perspective, it's important to be as aggressive and as safe as possible. It makes a big difference in terms of outcomes from a quality and quantity standpoint. And we're certainly able to do that here at Yale. We try to work as collaboratively as possible with the community, knowing in the end, we just want our patients to have the best care possible and be as close to home as possible. And then feel free to reach us anytime. There's our number and there's my email. Thank you. So next, it's my pleasure to introduce Dr. Nick Blondin. He is one of our wonderful neuro-oncologists and assistant professor.
Thanks, Dr. Moliterno. Can you see my screen? Let's see the thumbs up. Excellent. Thanks again for the opportunity to present here. I'll be providing some neuro-oncology updates in brain tumor management. For disclosure, I'm the Yale principal investigator from a trial sponsored by the nonprofit Global Coalition for Adaptive Research, or GCAR. And I also have done consulting and speaking for Novocure, the company that produces the Optune device. I produced this into presentation myself. So I'll be providing updates on glioblastomas and then a few slides on meningiomas. As you know, glioblastoma is the most common malignant primary brain tumor in adults, and it arises from the malignant transformation of glial cells, which are the normal supporting cells of the brain. The tumor is composed of nodules comprising the bulky tumor, as well as infiltrative glioma cells that diffuse through the brain tissue. And because of this infiltrative nature of the disease, the tumor unfortunately cannot be cured by surgery. However, the extent of surgery does affect the prognosis, and patients that can have a more extensive surgery or gross total resection will live longer. And then following maximal safe surgical resection, patients will require further treatment or else regrowth will occur, typically starting within 2 to 3 months after the initial surgery. And these follow-up treatments comprise radiation and chemotherapy. Glioblastoma is typically discovered in an adult that has a first-time unprovoked seizure. Other symptoms which can arise leading to the discovery of a glioblastoma can include progressively worsening headaches, visual changes, the onset of focal weakness or sensory impairment, or cognitive impairments such as change in personality or memory. Typically, these neurological symptoms will lead someone to see their primary care doctor, a neurologist, or seek treatment in ER, where imaging is done, demonstrating a mass in the brain. Then we obtain an MRI of the brain, which typically has characteristic features of glioblastoma. They appear as mass lesions within the brain, typically causing swelling around that region and compression on other brain structures. And we usually can have a suspicion based on the MRI that this tumor is in fact a glioblastoma. However, we need surgical intervention or a biopsy at minimum to have tissue to determine that the tumor is in fact a glioblastoma or GBM. In terms of prognosis for glioblastoma, there's a few factors which impact prognosis. A critical one really is age of the patient. So particularly for patients age 70 and older, they may have more complications that arise from treatments, including radiation and chemotherapy. And so different treatment considerations or de-escalating therapy may actually be preferred for this patient population. The extent of surgical resection also has an impact on prognosis, as I mentioned. And then the performance status of the patient following their surgery also impacts prognosis. And I show us a picture here on the side of the slide for the Karnofsky performance status of seeing how a patient is. And the hope is that following their surgery, the patient will have a full recovery and get back to 100% normal functioning and ability to work. Typically, patients will have a good recovery. A Karnofsky scale of 80 to 90 is like a good goal even to shoot for initial recovery from surgery. And the performance status really just depends on where the tumor was located in the brain and the size of the tumor at which it was discovered. And then more recently, we've discovered that there are some molecular subtypes of glioblastoma that also have a very significant implication for prognosis. Two main factors being the MGMT status and IDH1 status. And more recently, we've discovered other mutations are also important to help prognose a patient. In terms of the standard of care therapies for glioblastoma, after the patient undergoes maximal safe surgical resection, they receive radiation therapy along with temozolomide chemotherapy, or TMZ. TMZ is pills, which is taken at home. It's a kind of chemotherapy that damages DNA in the cell called an alkylating chemotherapy, and is given with radiation and then subsequently in monthly cycles. By combining temozolomide chemotherapy with radiation in a clinical trial population, the average survival time was improved from 12 months to 14.6 months. And temozolomide has been the standard of care for treatment since 2005. A second-line chemotherapy, which is also commonly used, is bevacizumab, also referred to as Avastin or Mvazi. And bevacizumab is a biological drug which binds a hormone called VEGF that is responsible for brain swelling and growth of blood vessels into the tumor. By administering bevacizumab, patients have improvement of brain swelling, sometimes experience shrinkage of tumor or stability. And in a clinical trial, addition of bevacizumab increased average survival time in patients out to 16 months, some patients going longer. And it didn't matter if patients received bevacizumab up front for treatment, along with radiation and temozolomide, or if they received it at recurrence. So it's typically saved for use in recurrence. Finally, the Optune device has been approved for treatment of newly diagnosed GBM following completion of radiation therapy. Optune is a portable medical device that delivers an electrical field that inhibits the mitosis of tumor cells, functions as an anti-mitotic therapy, and is intended to be used along with temozolomide cycles. In the clinical trial population, patients that were willing and able to use Optune, the use of Optune increased the average survival time from 19.8 months to 24.7 months. So these are the three standard therapies which typically offered to essentially all of my patients for treatment consideration. And you see we have improved average survival time by about doubling over the last 15 years, but there's certainly more to go. Additional chemotherapies could be considered for select patients, and these include lomustine, the PCV chemo combination therapy, regorafenib, or other targeted therapies. And these are in the NCCN guidelines. And so I touched on molecular features being important for prognosis. It was discovered about 10 to 15 years ago that the MGMT status is important for prognosing a patient. MGMT is an enzyme that can repair the damage done to DNA from temozolomide chemotherapy, and the gene is controlled by a promoter which is turned on and off by methylation status. Methylated tumors have turned off the promoter, and so the enzyme is in low levels in those tumors. Thus, patients with methylated GBM have more sustained damage from temozolomide chemo, and those patients will live longer. So MGMT methylation status is important to figure out for patients, and we assess this on all of our patients. Secondly, the IDH1 status is also important to determine. This is a gene involved with tumor metabolism and is typically mutated in astrocytomas, a less aggressive kind of brain cancer. If glioblastoma is discovered with IDH1, that indicates that in fact it was an astrocytoma originally, which has become more aggressive, but still may have a better prognosis compared to a tumor which has a normal IDH gene that's referred to as wild type. And then recently, other mutations have been discovered that have targeted therapy options. These include the BRAF V600E mutation, NTRK fusion, both of which have FDA-approved therapies. And FGFR3 fusion is under development currently with a few drugs being devised for treatment. Also, mismatch repair deficiency if that's discovered in the tumor, pembrolizumab or Keytruda can be used. It's FDA indicated for treatment in those tumors. And I have here a picture of both what a Foundation 1 report would look like up at the top, showing those genomic alterations identified, and our own in-house system, our whole exome sequencing, as Dr. Moliterno referenced. The benefit to the whole exome sequencing is that beyond just looking at the genomic alterations identified, we learn about copy number alterations. And copy number alterations occur from gain or loss of chromosomes. And we know now glioblastoma is comprised of many chromosomal abnormalities, gains and losses of chromosomes or chromosomal fragments, and that contributes to their malignant behavior. And then immunotherapy has made many gains in cancer treatment over the last several years. It's still in development for glioblastoma. As I mentioned, Keytruda is approved, but only in tumors exhibiting DNA mismatch repair, which is a very small percentage of GBM. A few studies have been done in the Checkmate 143 study of recurrent GBM treatment. Patients received either nivolumab, Opdivo versus bevacizumab Avastin, and average survival time was equivalent in the clinical trial population, approximately 10 months. Newly diagnosed patients were also studied with nivolumab with results forthcoming, but there doesn't seem to be a big impact overall for those study populations. And then recently, a study was looking at pembrolizumab or Keytruda treatment in patients with recurrent GBM that could receive surgery. And in patients that entered the study and received pembrolizumab along with surgery for recurrent GBM, their average survival was 417 days versus 228 days in patients that received Keytruda alone. So this is in further development. We have a trial coming up at Yale, which I believe Dr. Omuro will be talking about later in this talk about this strategy. And then for our patients, critical factors of glioblastoma treatment are corticosteroid management and anticonvulsant management. So corticosteroids like dexamethasone can be extremely helpful to treat brain swelling, make patients feel better, reduce neurological disabilities in the short term. But with long-term steroid use, a number of adverse effects can happen due to hormonal changes in the body. Patients can develop diabetes, fractures, bone weakness, and lethargy, and a condition called adrenal insufficiency. So managing corticosteroids closely is important, something I look at with every patient, every visit, every time. What dose of dexamethasone are they on, and can I get them off? And the usage of bevacizumab as a steroid-sparing agent has come into the fore in neuro-oncology, and it's quite a helpful drug to get people off of steroids if they've been on for too long. And other features that we have at our Brain Tumor Center that are critical for patients are counseling and social work. As Dr. Moliterno mentioned, we hook up the patients with our navigator and work with them, figure out disability for them and how to move forward with their life after this devastating diagnosis. And I think about for patients physical therapy, rehab, exercise, and the role of nutrition. All right, now I'll just briefly talk on meningiomas. As Dr. Moliterno mentioned, meningiomas are typically thought of as benign tumors, but they may not be benign in nature, or they can cause pretty significant neurological disabilities for patients. These tumors arise from the neoplastic transformation of arachnoid cap cells and typically are identified as a solid nodule, which may be calcified. There's 3 grades historically of meningiomas, grade 1, 2, and 3. But as Dr. Moliterno mentioned, we now know that based on the genomics of these tumors that appear to be grade 1 on histopathology may actually act in a more malignant fashion like a grade 2 tumor, or even more significant. So I drew some arrows here. The red arrow is pointing at a small meningioma. The blue arrow is pointing at a large meningioma. Small and asymptomatic meningiomas may not need treatment beyond observation, but large meningiomas typically cause symptoms. Those are symptomatic meningiomas, and those require treatment. Neurosurgical intervention being the primary treatment modality, and then radiation therapy being the second treatment modality. So if patients have exhausted surgical and radiation treatment modalities, but still are in good enough condition to undergo some kind of further tumor-directed therapy, medical therapies could be considered for treatment. We can look at their genomic analysis and see if in fact there may be a targetable mutation, such as the SMO mutation, which hedgehog pathway drugs may have some effect in. That's being studied. And then recently a paper was published looking at a combination of everolimus and octreotide. So it was the phase 2 Savorum study. And in this study, approximately half the patients had progression-free survival after a year, which is better than historical trends for this patient population. And then pembrolizumab also exists, again, for tumors that may have mismatch repair deficiency. And I manage patients with newer anticonvulsant drugs such as lacosamide, brivaracetam, and others. And these drugs have less side effects than the older anticonvulsants like Depakote or phenytoin, and better seizure control. All right, and I think at that point, I'll conclude my talk and pass to Dr. Bindra in our radiation oncology division.
Okay, can you folks hear me? Wonderful. Okay, well, thanks so much. A wonderful series of talks. And I'm going to tell you a little bit today, an update on some of what we're doing in radiation oncology as it relates to primary brain tumors, and recognize that we have a diverse audience of physicians as well as patients as well. And so thank you so much for coming. Here are my disclosures. We'll not be talking about any of these companies that I've recently started, but really just dive right into it. So we'll start with some advances and new approaches in radiation therapy at Smilow, then move on, tell you a little bit about proton therapy and its hopefully soon to be arriving plan on the horizon. And then we'll end with a little bit of work that I also do in the laboratory. I spend about half my time running a glioma lab, trying to translate work into the clinic. So a few interesting technologies that have been really progressing and developing quite nicely at Yale. We are very actively using something called the Novalis Exact Track system for CNS tumors. And this is just a schematic of the instrument showing the patient here. This is a 6-degree couch, which means that 6 degrees of freedom can move side to side, front to back, and then can actually tilt. And it actually has imaging sources that come at what we call orthogonal angles, and they can be repeated to get very, very close, accurate delineation of the treatment area during treatment. And this is sort of just a little snapshot of the imaging that we get from those orthogonal KV images. And we actually have automated alignment algorithms. So we can actually get down to about 0.3 millimeters of accuracy in a frameless system. Using the Novalis platform at Yale, we're able to treat a very wide range of primary CNS tumors as well as metastases. And these are just some heat maps showing incredible focused delivery, sparing areas like the spinal cord, and then shown here, critical areas like the brainstem. In parallel, we also have a very active gamma knife radiosurgery program, and Dr. Moliterno and the team here are involved with this as well. But this program is led by Dr. Chang and Dr. Yu, and it's really a fabulous program, and it's great to see it evolve over the last 20 years. I was actually a medical student here in the early 2000s, and I've seen this program grow. For those of you that don't know, the gamma knife is essentially about 200 sources of pencil beam radiation that are focused right on the tumor. And by doing that, we can achieve a very, very significant steep dose drop-off shown here. And we can treat tumors that are 1 millimeter, if not, or areas that are 1 millimeter or smaller in patients. And this is typically using a frame that we affix to the patient. But you'll notice in this picture, we have a new instrument called the Icon. And that's actually shown here. This was just set up over the last 2 years. And this is really state-of-the-art radiosurgery at Yale. And using this technology, we're actually able to treat patients without a surgical placement of a frame. So these patients can lie on the table, have a mask placed on them, and have a little bit more freedom to move while still maintaining a very accurate treatment. So what sort of treatments do we do with these technologies? So we can really treat all sorts of primary and brain metastases with this approach. We do treat glioma, both newly diagnosed and recurrent, with these technologies and modalities, meningiomas, as we just heard about, acoustic schwannomas. We also treat pediatric brain tumors, especially when we're very concerned about dose exposures in critical areas, as well as rear radiation, brain metastases, and other non-cancer indications like trigeminal neuralgia, for example. These are just two case studies from our practice. This is a 56-year-old female with a grade 1 meningioma who had a wonderful resection, but wasn't safe to remove all of it. And so we're able to come in with our ultra-precise Novalis exact track approach and using a rapid arc conformal plan that we generated. You can see here the dose outline that we're able to avoid a lot of very critical structures, such as things like the optic apparatus, as well as other parts of the brain. So this is really a very useful technique, and again, a frameless approach for precision radiation. Here's just another example of how we use the Gamma knife, and this is brain metastases. This is a 64-year-old female with a newly diagnosed non-small cell lung cancer who was found to have brain mets at the time of diagnosis. When you look at the scan, you would immediately think that this patient needs to go to whole brain radiation therapy. This is for the clinicians in the room, and certainly that would be a reasonable approach for this patient. But recognizing the immunotherapies and all the targeted therapies, the question is whether we could treat with a more focused approach if there is a chance for longer survival for this patient. And that's exactly what we did. This is a case from Dr. Chang. Dr. Chang went in and just as Dr. Moliterno presented that wonderful case earlier of a lesion that was affecting the speech shown here, and then a large lesion causing a lot of mass effect shown here. She was able to resect those critical lesions, and that's again shown by the arrows, and then actually use that frame-based single fraction gamma knife, so single fraction radiation to the smaller lesions that were there, as well as the cavity of the resected area. But recognizing these other areas need to be treated, like this and this, but they're larger, she was then able to use the icon system to deliver 5 fractions in a hypofractionated manner to some of these other areas where it would be more safer to use that. So really an excellent example of how we use all these new modalities to really push the envelope on what we can do for patients with brain tumors. This is just for the clinicians in the room showing the dose distribution. We get very, very nice dose drop off using this approach. So moving along, just want to tell you a little bit about proton therapy. Again, recognizing there are patients as well as caregivers on the call tonight. So protons are a fascinating modality. As some of you may know, conventional x-rays, which we use for most of our patients, are really good. And I showed you those focus plans at treating the tumor over the normal tissue, but they still have something we call exit dose. And that's shown by the tumor area here with the exit dose where the radiation doesn't stop. Protons have something very fascinating called a Bragg peak. And essentially you're throwing dose at the tumor and it stops right at the edge of that tumor margin. Okay, and just showing you that again, that with a more schematic of a patient, you can see a little bit of exit dose for the tumor, but then when you have a proton-based approach, you have a complete drop-off of the dose. So very, very nice advantages for a variety of tumors. In particular, I'm one of the pediatric brain tumor doctors, Radonks here, and this is a plan, what we call craniospinal radiation, and this is a pediatric medulloblastoma, and this is our normal conventional plan. This is the standard of care, and you can see there's a lot of exit dose here, and at first glance, you think maybe just the abdomen would be at risk, but you can see here, actually, it's the heart that we worry about for patients that could live for 50, 60 years, depending on their age. And using proton-based radiotherapy, you can see that we're able to completely stop the dose into those critical structures. And this is a slide from Dr. Ken Roberts, who's leading our proton development plan in Connecticut, along with other folks. So where are we with protons? So just one slide to show you that it is coming soon. We have a certificate of need that's been filed, or about to be filed rather. We believe that within about 21 to 24 months, we'll have the IBA Proteus 1. This is one of the state-of-the-art pencil beam scanning proton IMRT devices. We'll be able to offer that, and we're doing that in collaboration with the folks at Hartford Healthcare. So do stay tuned. We're really excited about these developments. In the meantime, though, we have a lot of patients that will need craniospinal radiation of various ages, and they might not be able to go up to a proton facility in New York or Boston. We certainly send them when we can. And at Yale, what we've been able to do recently, really, this is Ken Roberts in our department, has developed a protocol for VMAT, rapid arc craniospinal radiation. And this is essentially using those photon plans that I showed you earlier and using a dynamic arc to sculpt the beam. And this is what a conventional craniospinal plan would look like I showed you earlier. But using VMAT, you can see we actually get a pretty good sparing, although we have a lower dose bath that I'm not showing you here, but certainly better than the alternative, the conventional approach. So we're using this quite actively in patients, and certainly feel free for the clinicians, the radiation oncologists, to reach out to us if you have a case that you may be interested in discussing with us. This is a case of a 25-year-old female with GBM who had a local recurrence, but unfortunately had leptomeningeal spread throughout the, with tumor studying the spine. And we're actually able to design quite a nice craniospinal VMAT plan. And this is also shown for the radoncs in the room, the plan sum for the original radiation there is shown in the heat map. So again, really a lot of flexibility in the way that we use this technique for a number of cancers, and certainly just reach out to us if you're interested. Finally, in the last 2 minutes, just want to show you where we're headed now with some of the bench-to-bedside research that we're doing. Again, we don't have time for this today, but our laboratory is very interested in developing novel therapeutics for the treatment of gliomas and other brain tumors. And we've been very lucky to publish some exciting work shown here on the left in Nature and some other journals. But more importantly, we've been able to translate that directly into clinical trials. And as you can show highlighted in red, a number of them for brain tumors. A lot of this work comes from the groups here at Yale, including Murat Ganel, Peter Glazer, and others shown here. And in particular, there is one study that would may be of great interest to the brain tumor folks on the call today. This is a study testing a novel DNA repair inhibitor called a PARP inhibitor, combining it with temozolomide chemotherapy for patients with IDH mutant recurrent glioma. And this is based on our laboratory's work. This is a trial that I run with Dr. David Schiff, and Antonio Omuro is one of the PIs as well. We have actually just finished the dose escalation phase actually this morning. So we are now entering the phase 2 component, and certainly would love to hear from folks. If you have a patient, call Dr. Omuro or myself. With that, certainly just email me. Just want to give you a brief kind of smattering of what we're doing down in Smilow Radonc. Email me, check me out on Twitter, see what we're up to in the laboratory, and also you can come to our website. And again, thanks for joining us this evening. It's really great to see so many participants. I'll leave it at that.
Thanks, Ranjit. And then finally, we're going to hear from Dr. Omuro, who is Chief of Neuro-Oncology.
Thank you everyone for staying this late and to talk about brain tumors. It's really a pleasure to be part of this great meeting and to chat a little bit about what's going on in terms of clinical trials and translational research in our field. Here are my disclosures. I do clinical trials for a living, so I have contacted many companies and worked with many companies in terms of research support. And these are companies that for which I provided advice. So we have only a few minutes, but I would like to give you a broad overview of what's going on and in which direction the field is heading in the next few years. So of course, the first major advance in our field was the availability of gene sequencing to guide us in terms of diagnosis and in terms of potential experimental treatments. So Dr. Blondin has already alluded to this, but the reality is that we are dealing with brain tumors that are extremely heterogeneous from a genomic standpoint. So what you're seeing here is all gliomas, and what you can see is that there are very distinct signatures depending on the type of the tumor that we are dealing with. So that starts with oligodendrogliomas that have a very typical signature of IDH mutation, 1p19q deletion, third promoter, CIC, and a few PP1 mutations. And that is in contrast with the glioblastoma that have EGFR mutations, PTEN, CDK mutations, and MDM2. So this is great for diagnosis, and we certainly use this in clinical practice. But the question is how to translate this into therapeutic advances. So Dr. Blondin has already alluded to this a little bit, but the reality is that only a very small proportion of these mutations are actually druggable. So what you're seeing here is the same of those patients now divided into whether there was an actionable mutation or not. And here looking at the percentages of these patients, and as you can see, the low-hanging fruits, for example, BRAF mutation, is only present in about 1 to 2% of the patients. And same thing goes for all of these other mutations that for which there are potentially available treatments, but they are very challenged to study because, again, these patients are spread out, sometimes in the community, sometimes they don't get to us, and it is hard for us to deliver clinical trials for these specific mutations. Of course, the low-hanging fruit is IDH1 mutation, and Dr. Bindra already alluded to that as one of the very important mutations that can be potentially targeted in various ways. But for the most part, the other mutations, it remains very challenging to run clinical trials that are specific for them. One trend nowadays is actually conducting what we call basket trials, where patients are enrolled, selected by the mutation and not by the disease itself, which means that patients can be enrolled in a trial together with breast cancer, with lung cancer, and prostate cancer. Unfortunately, in our case, a lot of the trials do exclude patients because of brain tumors. The brain tumor location exclude them from participating in the trial. So we have to do a lot of lobbying with the drug companies to really push for basket trials that actually allow our patients to be enrolled. Fortunately for us is that we have a very strong phase 1 group here at Yale, and we are able to find trials, and if we don't find trials, we do make every effort to contact the drug companies and see if they can provide this drug on a compassionate use protocol. And the other challenge that we're facing now is that, well, this is all great, but the sequencing is typically done at the time of diagnosis. And here you're looking at several potentially actionable mutations on this patient that had an astrocytoma. And this patient was treated successfully initially, but then the patient had a small recurrence, and a lot of physicians would not ask for surgical resection here. But because this patient had a very good course and this was a very favorable location, we convinced our surgeons to go after this. And what we found is that all of those potentially actionable mutations were all gone, replaced by passenger mutations that are not relevant. And what was driving the malignancy here was really changes in the epigenomic landscape. So this makes our lives a little harder because we can imagine that we are trying to enroll these patients in targeted therapies based on this type of mutation. But the reality is that what we really need is to have an update information on the genomics so we can match these patients in a more efficient way. So here's just a summary of where we're heading, right? So I think right now, one of our major focus is really on phase 0 trials. And what this means is that we are trying to give drugs to the patients and then resect the tumors and then have more information on what kind of targets our new treatments are really hitting and whether they're really doing the job that they're supposed to do. The other trend that I just alluded to was the basket trials that are getting more and more efficient, but it also, again, carries the challenge of excluding patients with brain tumors. And then, again, the other trend right now is to really resample recurrent disease. That's really important. So one of the applications is really to exclude the hypermutator phenotype, which Dr. Blondin has already alluded to. And again, as I mentioned, to update the gene sequencing. Another trend right now is to target what we call truncal mutations. So these are mutations that arise early in the oncogenetic process, and they are very conserved throughout the history of the disease. And these mutations are not so easy to target. This depends a lot on what we call functional genomics, so studies that define vulnerabilities that are associated with these mutations. And that is one of the paradigms that Dr. Bindra used to develop his trials in IDH mutations. So, and overall, what the field is actually doing as a whole is actually moving out of these very selected target to alternative strategies that are more stable in the course of the disease. So one of them is immunotherapy, and Dr. Blondin already summarized to you that unfortunately immune checkpoint inhibitors have largely failed in glioblastomas. There is many reasons for that, and we're trying to understand that. We published the first study of immune checkpoint inhibitors using nivolumab and ipilimumab over 4 years ago, and there has been a lot of advance in trying to understand how the brain handles the immunologic system in a way that is both protective of the brain, but unfortunately also protective of the tumor. So to study this further, what we did was to enlist specialists in the immune system in the brain. So a lot of the work in cancer is done by immuno-oncologists, but we're fortunate enough to have at Yale access to amazing neuroinflammation specialists, if you will. And one of them is Dr. David Hafler, who studies inflammatory diseases in the brain. And his hypothesis is that a more relevant checkpoint in the brain is this novel molecule called TIGIT. So this is a novel immune checkpoint that seems to have a very important role in the central nervous system. For example, it is lacking in patients that have multiple sclerosis. And the expression of TIGIT is very frequent in glioblastomas. So to investigate this further, we partnered with Dr. Moliterno and Dr. David Hafler's lab with Liliana Luca and others. And what we're doing is a national trial, a multi-center led by Yale, that will randomize patients that are candidates for surgery to either receive anti-TIGIT antibody, anti-PD-1 antibody, anti-TIGIT plus anti-PD-1 antibody, or a placebo. And that is just before the surgery. After the surgery, all of the patients will have access to both the combination of anti-TIGIT and anti-PD-1. And what we're going to do is to really look at these tumors and paired blood samples and perform state-of-the-art translational studies, including single-cell RNA sequencing, utilizing the 10x genomics at the Yale Center of Genome Analysis. So this is a very exciting trial that will actually tell us who are the patients that are really mounting effective immune responses in the brain. And we hope to learn a lot about whether this hypothesis is correct. And hopefully these patients will also benefit from the fact that these drugs are being given in the what we call neoadjuvant setting. Another trend is to perform studies in parallel with the clinical trials. And in this particular case, what we're going to do is to study these drugs in a more systematic way by utilizing genetically engineered mice. So these are models developed by Dr. Sidi Chen that has these amazing technologies to really create what we call patients' avatars. So basically, these are mice that will develop tumors that resemble certain patients. So we get the combination of mutations, and then he creates these models which are utilizing CRISPR technology. And then we will treat these animals with the same types of combinations to see how these novel agents behave in the setting of the different mutations that are associated with these tumors. So this is very exciting work that again is going in parallel, that will inform us the clinical trial and then hopefully help us select patients in the future that are more likely to benefit from each of these treatments. Another clinical trial coming up in January is coming from this company called Neuro-Pharmaceuticals. And what they did is that they discovered a novel receptor within the alpha V beta-3 integrin that is targeted by this new drug called FBPMT. And this has an amazing activity in tumor cells, in the tumor microenvironment, and angiogenesis. And we'll have the first in-human trial here at Yale. And once again, we're conducting laboratory experiments in parallel as we develop the trial to try to understand this drug a little bit better in terms of what it does to cell invasion proliferation, activation of the signaling networks, and gene expression, proteomics, and phosphoproteomics studies to see if we can, again, identify who are the best candidates for this type of treatment, and also identify which are the best partners to be combined with this drug in the future. And this is all work being done by Dr. Andrei Levchenko here at Yale. Another superstar laboratory scientist here at Yale is Dr. Iwasaki. Some of you may have seen her in the media. She is our COVID-19 specialist, so she's all over, and in fact, this is catching her attention from her work in brain tumors, but she's very interested in developing novel treatments for glioblastoma because of her interest in the immune system in the brain. And with work done by Eric Song and John Thomas in her lab, in a very high-profile paper published in Nature this year, she found that really one of the problems of the immune system activation in the brain is actually linked to the lymphatic drainage that is very defective in the brain. And then she discovered that with VEGF-C, she could potentially modulate this, and then eventually the patients started to, or the patient, the mice started to respond to the immune checkpoint inhibitors and other forms of immunotherapy. So she started curing mice by adding VEGF-C to the immunotherapies. So this is very exciting work that we hope to be translated into a trial in the near future. Dr. Bindra already alluded to his work in DNA repair. Yale has a long tradition of work done in this space. In fact, a lot of the very early studies were actually done here. And Dr. Bindra continued with that tradition and launched a bunch of clinical trials looking at PARP inhibitors in IDH mutant gliomas. Also going on here is expanding on some of the work on DNA repair and extending to MDM2 inhibitors. We have partnered with Mayo Clinic to develop two early phase clinical trials. One will be investigating MDM2 inhibitors, and the other one will be, that is led by Jun Sarkari and Eva Galanis at Mayo Clinic in partnership with us. And Dr. Bindra and I will be working on a project to develop ATR and ATM inhibitors. And this is, again, very exciting work. And we are fortunate to have Pat LaRousse, who's also a DNA repair specialist when it comes to drug development. And this is a really exciting new development here at Yale. And we don't have time to go over all of our trials, but here is just a non-exhaustive list of what's going on. We also have inhibitors of IDH mutant for low-grade gliomas, with the idea that if we intervene in these tumors earlier when they're not behaving in a malignant way, maybe these drugs are more effective. We have drug combinations for BRAF V600E mutations in gliomas, craniopharyngiomas, and all other brain tumors. Dr. Blondin already alluded to regorafenib and how that could potentially improve survival in newly diagnosed and recurrent GBMs, and this is an ongoing trial that's really exciting. We're exploring another potential clinical trial with enzastorin, and this is for patients that have a germline biomarker called DGM1. So again, trying to deliver on this promise of personalized medicine. This is a drug that could potentially help patients that have this biomarker, whereas the patients that do not have the biomarker do not seem to respond. So this is another potential concept that we will be exploring. We have chemotherapy regimen trials for 1p19q colloidal organogliomas. We have mutation-driven clinical trials for brain metastasis and for meningiomas. So this is all happening right here at Yale, and we hope to see more and more patients enroll in our clinical trials so we can advance the field and try to match these patients with the best experimental treatment available. And we are very fortunate to have all of these people working across multiple schools here at Yale that will be helping us to really make a difference in this space. Thank you very much for your attention.
Great,
I'll
thanks
pass
so much,
back to
Antonio.
Dr. Moliterno.
Yeah, so we will open this up to questions. I guess what we could do is if you want to submit any questions to the chat, and then I can just read them off.
As well as the Q&A, Jen, there's the separate bubbles as well.
Oh, I see that. Yeah. So, okay, so there's 2 questions on Q&A. So that's where we can work with the questions. So first, does dexamethasone contribute to tumor growth? Nick, you want to?
I can take on that question.
Sure.
So I think that's an excellent question, and that is something that people have asked for a long time. Part of the concern came from the literature in prostate cancer, where many preclinical studies were done raising concerns about the use of steroids and how they could have a detrimental effect on tumor growth. So in gliomas, this has not been so clear. We dislike corticosteroids because of the many side effects, particularly proximal myopathy, increase in hyperglycemia. In fact, hyperglycemia itself is a well-known factor that actually induces tumor growth and is associated with a worse prognosis. So it wasn't an indirect effect, but not necessarily a direct effect of the steroids. But in terms of direct effects on the tumor, we were sort of reassured by the literature on Avastin. And that is because people who received Avastin used less steroids, and yet they did not live longer than patients that actually were on the control arms and received a lot of steroids, and then they lived just as long. So that's sort of reassuring in terms of that it's not having a direct effect. But again, steroids have lots of other unintended side effects, and we try to avoid the use of those. And I think it is a huge issue for us if we want to develop successful immunotherapies. So that is potentially the main issue right now with the steroids. Patients that are on high dose of steroids, they're basically excluded from immunotherapy trials.
And of course, from a surgical perspective, wound healing is always a concern. Okay, on to the next one. Is there any investigation of the utility of hypomethylating, I think that is, agents in neuro-oncology?
Those have been studied in the past, and the studies were not successful. It was some years ago even. So I can't remember the name of that product, but the theory was to induce methylation with another drug, and it just didn't seem to alter outcomes for patients. Not sure, Dr. Omuro, if you recall more about that product.
Well, there's a host of preclinical data on this, particularly in IDH mutant tumors. I think the jury is still out. I have used some of these agents off-label, and I have not seen responses, but the reality is that good clinical trials that are more informative have not been conducted, especially selected for IDH mutations. And I can also let Dr. Bindra comment on this.
Yeah, no, great, wonderful question. And there was a trial with vorinostat and radiation led by the NCI. It was not randomized, had some good results, but really wasn't robust enough to move forward. And as Dr. Omuro mentioned, the IDH demethylating story is really unfolding in the AML world. There's a lot of interest in combinations, and I do believe it will be making its way up in the context of combination therapies. So certainly more to learn soon.
Okay. Next question. Have you had any experience with personal vaccines?
Well, I can comment on that. So I think vaccines are a work in progress. The majority or almost all of the vaccines have not panned out in randomized trials and well-conducted randomized trials. So I've done several trials of those, including the Greek cell vaccines from the same patient. There are trials now. The trials are getting better and more sophisticated, but vaccines by themselves are still to find a niche in oncology in general. Unfortunately, most of the trials have been negative. So I think vaccines may be part of the answer in the future, but on their own, it is going to be, again, it's a work in progress.
My thought is it could be very complex to make the vaccine product. I was involved with a study to develop a heat shock protein vaccine from tumor tissue lysate, and it was just a very complex product to generate the vaccine. Then the second issue being, even if the vaccine is generated successfully, there can be factors within the patient that inhibit the vaccine from working effectively. We don't understand really what those are. Probably the biggest vaccine story is a vaccine against EGFR V3 called Rindopepimut, which seemed to have great data in earlier studies, phase 2 studies, and then when studied in the pivotal trial, phase 3, appeared to be completely ineffective to improve survival of patients with the biomarker. And it's still unclear to me what exactly the factor is, and it's probably a number of factors related to the GBM suppressed immune microenvironment.
Okay. Next question. Will it be possible, I just lost it. Will it be possible to use protons on a meningioma that's in the cavernous sinus, which is next to the pituitary gland and the optic nerve? From a surgical perspective, a few things I would comment on, and then Ranjit can comment. So these primarily sphenoid wing really meningiomas or skull-based meningiomas, we're actually in the process of studying them. And those were some of the ones where the genomic driver mutation can really determine how we treat them, or at least how we use it in our tumor board. So sometimes, depending if there's a component of that tumor that's a little bit more exophytic that can be surgically accessible, we will advocate for the removal of part of that. Also, one option as well, which we have done too, is if the optic nerve is nearby, if we can decompress the optic nerve from a surgical standpoint, that can help preserve vision or even have the return of vision. I actually did a case like that just a few days ago, last week. And then also that can help preserve the vision in the other side. So usually, at least in our hands, we like to exhaust all the options, understand the tumor from a genomic standpoint. For ones that clearly don't need surgery, I think we weigh different factors into when we radiate or don't radiate, you know, in terms of the patient's age and follow-up and growth and symptomatic and that sort of thing. But I do think genomics plays a big role in the genomic driver of the tumor. Ranjit?
Yeah, it's a really, really great question. And actually, your response highlights what's great about the institution. We have such a close relationship with all members of the neurosurgery, neuro-oncology, radiation oncology team, talking about what is the best modality. And often, you know, we start with surgery. And if radiation is needed, you can think about things like the icon and the gamma knife that we talked about earlier, which actually has the same dose distribution as protons. And if not, fractionated radiation. And the question there is whether you would need protons. Most of the times we don't feel there is a need. If the patient needs radiation, we can do quite well with gamma knife or using our regular Linacs, so to speak. But there are certainly cases we send to referral for protons. So wonderful question.
And wonderful response. Can supplements like antioxidants, et cetera, be used during radio and chemo treatment that are there studies that suggest a possible beneficial outcome? Vitamin C,
I think the biggest issue is that no, there are not studies. And supplements are difficult to study. Some may be plant-based or botanical products, which are even more complicated to study than pharmaceuticals. So there really is no great data behind any of these studies, unfortunately, behind, you know, except for some limited lab or preclinical data. So in terms of using supplements, in my personal practice, I do have some patients that are interested in supplements and opt to use them, and I help guide the patient to make sure that the use is what I consider to be safe and not detrimental to the patient.
Yeah, I would add that certain supplements actually may result in worse outcomes, and this has come out in many studies in the past. I think in terms of antioxidants, I think they are something that is not recommended during the radiation. And I can defer to Dr. Bindra to comment on that, but typically high dose of antioxidants are typically not preferred during the radiation.
Yeah, we always get a little bit worried because the way the vitamin C, the structure and whatnot is, it's a free radical scavenger, as we've sort of alluded to, and so it can actually block the effects of radiation on tumor damage. So.
And I'll say it's true because he always stops the vitamin C that I put my patients on after surgery. So, and I don't argue.
I think for long-term patients that are using supplements, it's unclear to me that these are detrimental, but perhaps they could be beneficial to select patients, but again, we can't tell prospectively who will benefit from these. And that's an important factor to keep in mind when considering any kind of supplement.
And Jen, there's some 2 chat questions just to oscillate back.
I see.
They look quite interesting, as do the other questions too.
All right, so we'll make these our last. It looks like 5 total. So given there is a significant number of tumors who have the TP53 mutation, are there any current or upcoming trials that target this? And Mike also said thank you, so thank you.
So yeah, I'll take that. It is interesting that given some of these mutations that are so common that we haven't had a therapy. There are, trials in development targeting a related protein called MDM2 or MDM2 inhibitors, which actually act in the same pathway. So I think surprisingly, there's not been enough. It's been difficult to target that mutation. 50% of all cancers actually have this mutation. There's certainly new therapies around the bend that are trying to attack this axis.
Yeah, there are some compounds that are entering clinical trials that are mutant p53 reactivating compounds, and but again, they are in initial stages of clinical trials, and then we'll see if that pans out.
Next, is there any potential benefit to starting the Optune immediately following radiotherapy instead of waiting until TMZ? Is there any proven benefit for patients that wear it more than the recommended 18 hours a day? Nick?
So in the pivotal trial, Optune was initiated 4 to 7 weeks after completing radiation and then used with the temozolomide cycles and could be continued actually until the second progression for a patient. So that's the current indication for the device. There have been 2 pilot studies done where Optune was initiated at the start of radiation, and patients use the device actually during radiation treatment and following. And those seem to indicate some benefit to starting Optune that way without additional skin toxicity. So a large phase 3 study is planned to test this hypothesis, starting Optune at the beginning of radiation versus at the start at the end of radiation. That should be starting up next year. And then in terms of treatment usage, there is actually incremental benefit. So the more a person is able to utilize it, the better the average survival would be for a patient, particularly those that can achieve above 90% usage month to month. They had a longer survival time than patients that had less usage in the pivotal trial.
Yeah,
so the caveat being skin toxicity.
The patients cannot do that, and it's really difficult for them to use Optune 100% of the time. So it is a cumbersome device, and it is very individual. I mean, the choice of using the device and how that impacts their quality of life is very personal. Many patients choose not to go that route, and that is because they don't see themselves wearing that device 100% of the time. So unfortunately, the clinical trials were not properly designed that led to the approval. And basically, there was no, in that phase trial, the control arm was not blinded. And there was no sham device, which would be the best control for this type of trial, and that was not done. But in any case, the evidence points that there could be some activity, and some patients choose to use and others prefer not to use. Most clinical trials, they do not allow for the concomitant use of Optune.
Okay, next. If unable to access the neurosurgical care team on our case, receiving care from a team in another state, and we are put in an emergent situation like an extended seizure, for example, would it be best to admit to an ER within a hospital that has a functional MRI? Should I make that a priority while waiting to see if stabilization and transfer to care team is possible? I'm a caregiver. So, you know, this is a difficult situation in that most patients and care providers don't know, or caregivers rather, don't know what they're necessarily being told. And you see a neurosurgeon, and this neurosurgeon sounds pretty capable and competent. And so you don't really know. And a lot of times patients I see too are being told that, you know, this is emergent surgery and rushing to surgery and that sort of thing. What I always say is it's really important, I think, to get second opinions. Of course, you know, if it's life or death, that sort of thing, you don't have that luxury. Having said that, most tumors are not immediately life or death. And so there can be some time typically to consult with an academic center such as ours. Even if it is a long distance away, we frequently have those calls or emails or consultations. And so then you can understand what you're up against and what the recommendations would be, even if it's not realistic for traveling. But I would always suggest making sure and asking numbers too. You know, how many surgeries does the neurosurgeon perform a year, but how many brain tumor surgeries does he or she perform? And is this what he does, or is he a general neurosurgeon? Does he do spine neurosurgery, et cetera? And that can give a little bit more info about that. And then other people are just saying thank you. So thank you for thanking us. And then, oh yeah, there's more questions here. Okay, for recurrent GBM off study, do you use Avastin alone, or have you combined with lomustine or irinotecan?
Yeah, so I think most of us, based on some imperfect studies, ditched irinotecan, so that is no longer used in GBMs. It lacked activity as a single agent, and also in studies with Avastin. Lomustine, the jury is still out. I do offer that for patients that can tolerate that and they have MDMT methylation, especially if they responded well to alkylating agents. It's potentially helpful, but there are no randomized trials to prove that.
I really individualize it for a patient in my practice on their performance status, molecular factors. So Dr. Moliterno, I would like to add for outside opinions, with the COVID pandemic, telemedicine has expanded, and we offer telemedicine to patients throughout Connecticut. Telemedicine licensure still is a state by state. There is some movement on the federal level to get more reciprocity so we can do more telemedicine consults in different states, but that is something that we can take advantage of. And Yale has a good platform for telemedicine.
And even during the pandemic, we have been transferring patients from outside who want to seek the best care possible here. So yeah. Just because we were talking about Avastin, I think, why is Avastin called the last resort drug? And is that an accurate description? And there was another patient who also described that he has a GBM and did standard of care, et cetera, is now currently on Avastin. So why is Avastin used later? And do you consider it to be a last resort drug?
So I don't think last resort is a good term here. I think it is a very helpful drug. It's just that the timing to use the drug needs to be individualized. Avastin is excellent to rapidly shrink tumors and decrease the peritumoral edema, which means that the patients can improve very quickly. And for those patients that have really bad neurologic symptoms, that is the time to use Avastin.
And I know you guys have oftentimes used it even early on for, really large tumor burdens, multifocal disease, where I, am limited with what I can do with a extensive bihemispheric disease, that kind of thing.
Correct, and that's a great point. We use it when needed. It can be used up front. Sometimes the patients are in the hospital. How they're going to get out of the hospital if they have a large tumor, they can't talk, they can't walk. So these are patients that really need Avastin up front. And I think why there is so much concerns about the use of Avastin is because we sort of lose the parameter of what's happening to the tumor. So Avastin sort of cleans everything. And we do know that these tumors can sometimes continue to progress even though we're not seeing and not feeling it. But the tumor could be progressing, and a change in treatment will be in the order, but it's just that we can't identify when the change of treatment is. And for that reason, these patients are typically excluded from clinical trials. So that is the only downside of Avastin, but I think for those patients that require Avastin, they would not be candidates for clinical trials anyways, because they were not feeling well, they were not doing well, and they couldn't handle a clinical trial. So if Avastin is initiated, it's because it was needed. And I think there is nothing wrong about that. And I think it is a good drug, and I think it is vilified a little bit, but we now know how to use it and when to use it.
That Avastin is not very effective for the infiltrating tumor cells of GBM. And so what you may see is that a patient, after starting Avastin, after some months, will have worsening of neurological disabilities, and that's due to the infiltrative tumor cells spreading throughout the brain, which unfortunately can be resistant to all chemotherapies. Something that we're still, working hard on to improve treatments for.
Good. It seems they liked your responses. And then the final question, are you using Optune Novocure upfront for most patients with GBM, or do you use it in select patients?
Well, I think Dr. Omuro made an excellent point that Optune is cumbersome to use. It's a visible evidence that you have malignant brain tumor. It's up to a patient, it's something that they do. And as a neuro-oncologist, it's a FDA-approved treatment that I make patients aware of, offer it to them, tell them the data, and then it's up to a patient. Some patients are able to embrace Optune, use it effectively, and then others, it would be challenging for them, and it's not something that they think is worth it. And I respect a person's decision no matter which they choose, and help them, try to have the best treatment and outcomes that they could have.
Yeah, well, I had a patient that was an engineer living in the middle of the woods who was very averse to people, and he loved it. He were his devices. He was an engineer. He thought it was a really cool thing and did not bother him at all. So for that kind of patient, sure. And then I have my Manhattan patients that would never actually wear that because they would never want to go to work. They would not want to be seen wearing that. And for those patients, it was more important their appearance and their quality of life than the downsides of the potential benefits from Optune.
I think in the end, it's, again, what we're all saying is, a lot of these decisions are made in conjunction with the patients, and being informed is the most important thing, and being surrounded by expert opinions and experts in the field who can really give you all the options is really the most important thing. And we here are always available to answer any of those questions or give consultations as well. So, and I also see Chris Cusano, who's the president of Connecticut Brain Tumor Alliance. He thanked us as well, and we thank him for his continued support of our patients in the Connecticut Brain Tumor Alliance. It's a great organization for patients with brain tumors. So in conclusion, did you say vitamin C should not be taken while undergoing chemo or radiation? Yeah, we usually tell you to stop. I tell you to continue it after surgery, and these guys tell you to stop. It kills me to say that. But yeah, don't take it. Supposedly, that's what they say. But in any event, thank you all for being here. It's past 7:30. We so appreciate you being here and spending your evening with us. We hope to do this again in the future. For the providers that are on, we even hope to do really kind of like a mock tumor board, so you can bring your cases here and we can help provide answers, or even to patients. We can help offer our opinions and such. So we'll look forward to that in the future, and please just reach out and contact us if we could be of any help. And to my co-speakers, thank you so much. Have a good night.
Have a good night, everyone. Be well.